And how do we calculate? It's very simple. There's a formula. The age, the AST, the ALT, and the platelet count, you can use it, put it in your app, and you can get a value for that. Values less than 1.45, you can just keep these patients under your observation. Patients with a very high FIB-4 index, more than 3.26, these are patients who may be having advanced fibrosis. They might require a liver biopsy and they need more aggressive management. Indeterminate, you have to be more careful, keep a watch, and keep on testing for other fibrous markers like the ELF test or the elastography, like the VCTE or the MRE. So for the imaging, who should be subjected to imaging? Again, as I talked, you do a FIB-4 in a type 2 diabetic patient, and if you find there's a FIB-4 less than 1.45, nothing to be done. FIB-4 more than 2.6, probably these are already patients who are reaching cirrhosis, probably this test would be of no use. But of course, if this is indeterminate variety, then you go in for these tests like the VCTE, which is a vibration-controlled transient elastography, or you can do other tests which are not so easily available. What to do with these patients? Lifestyle management is the treatment of choice. Still in 2024, clinicians should recommend lifestyle changes. If you reduce your weight by 5%, chances are that steatosis will go down. If you can go up to 10 to 15%, then maybe the NASH may also go down, and there may be some regression of fibrosis as well. Clinicians must recommend dietary modifications, including a reduction of macronutrient content, and you can go for diets like Mediterranean diet. And of course, a participation in a structured exercise program should always be recommended. The basic aim is bring down the weight by at least 5 to 10%. But what about the pharmacotherapy? Remember, till date, no drug has been approved by US FDA as a treatment for NASH. So all these recommendations have come from the authorities, from the US authorities themselves, various academic associations, but none of them has been accepted by US FDA as the treatment of choice. Pioglitazone and GLP-1 RAs are recommended for persons with type 2 diabetes and biopsy-proven NASH. But then if you have a very high probability, even if you don't have a biopsy-proven NASH, you have an elevated plasma aminotransferase level for more than 6 months, and on non-invasive tests you are finding that a lot of fibrosis there, you can start with pioglitazone and GLP-1 RA. Now, SGLT2 inhibitors can be used, but however, there is no evidence of benefit for treatment of steatohepatitis with SGLT2 inhibitor. They can bring down the steatosis, but not the steatohepatitis. For steatohepatitis, the only two drugs that have shown some sort of a response are the pioglitazone and GLP-1 RA. Due to lack of evidence of efficacy, metformin, acarbose, dipeptidyl peptidase 4 inhibitors, and insulins are not recommended for the treatment of steatohepatitis. Vitamin E can be considered for treatment of NASH in persons without type 2 diabetes, but there's not enough evidence at this time to recommend for persons with type 2 diabetes or advanced fibrosis. All the other pharmacotherapies for persons with NASH cannot be recommended at present time due to lack of robust evidence of clinical benefit. Obesity needs to be managed, and there you can use GLP-1 RAs. Semaglutide has shown wonderful results. The obesity pharmacotherapy can be used to bring down the weight and thereby control the NAFLD or NASH. Clinicians must consider obesity pharmacotherapy, for example, semaglutide or liraglutide, as adjunctive therapy to lifestyle modification for individuals with obesity and NAFLD or NASH to promote cardiometabolic health and treat or prevent type 2 diabetes, cardiovascular disease, and other end-stage manifestations of obesity. Bariatric surgery is again an option, but probably not many would like to go in for that. Remember, compensated cirrhosis, the results are not very good, and decompensated cirrhosis is a complete contraindication to go in for any form of bariatric procedure. Saroglitazar, where does it stand? A dual PPAR alpha gamma agonist, saroglitazar has shown improvement in liver enzymes, liver stiffness, and metabolic parameters in NASH, though histopathological validation is still to be required. So again, a drug which is available, approved, but then we still don't have this approval from the authorities. A very interesting and a very heartening news has come. In March 2024, the FDA has approved resmetirom, that is Resdifra, for the treatment of adults with non-cirrhotic, non-alcoholic steatohepatitis with moderate to advanced liver scarring. These are patients with scarring and fibrosis, to be used along with diet and exercise. This is the first drug to be approved by the US FDA for treatment of NASH and fibrosis. Liver biopsies have shown a greater proportion of subjects who were treated with Resdifra or resmetirom achieved NASH resolution, or an improvement in liver scarring is as compared with those who received the placebo. So this is a very heartening news, and I think very soon these drugs would be available to most of us, and probably this will give us some more hope to our patients with NASH and NFLD. Resmetirom is a partial activator of a thyroid hormone receptor beta. So a very different type of a molecule, and its activation has shown that it reduces liver fat accumulation and has also shown to show regression of fibrosis as well. So this is the first drug to be approved by US FDA.
Can you please sum up?
So this is the end of the talk, and thank you for your patient listening.
Okay, loud round of applause for sir, an excellent talk. Now the topic is open for discussion. We will take 2 questions. Yeah, Dr. Meena.
Yes. Yeah. Yeah. How do we say that it is overdiagnosing? We have to compare it with some sort of a standard. So if you're comparing with an ultrasound, again, I said ultrasound is not a very good criteria. So patients may not show steatosis on ultrasound, may show steatosis on CAP. So saying that CAP is overdiagnosing probably would not be the right way to comment on it, unless we have some sort of standard. If we compare CAP with liver biopsy proven NFLD, if we find that on biopsy there was no NASH and the CAP was showing NASH, or maybe it's steatosis, then probably you can say it's overdiagnosing. Comparing it with another test, which is again not a very, what you call a confirmatory test, I think would not be the right answer.
So are they correlated with fat deposition in the pancreas?
Yeah. So it is a very similar type of a thing happening. It is basically steatosis not only happening in the fat cells, but it's also happening across the visceral tissues and including in the muscle tissues as well. A lot of fat is getting deposited in the muscles when there's excessive amount of free fatty acids available. This is all going into these muscles, the liver, the pancreas, endothelial cells, all of them are getting deposited with fat. We are talking about the fatty liver actually over here.
Last from Dr. Punit, yeah.
So regarding what Dr. Meena was saying, that we are over-diagnosing by fibroscan, I think it is other way around. We were under-diagnosing in the previous days, and the incidence and the prevalence is just as common as we are seeing with these scans, because they are validated, as you have rightly said, along with the biopsy confirmations. So I think it's a very common problem, and I think in this hall also, if we do ultrasound fibroscan, many of us will have some kind of fatty liver disease.
I think the take-home message should be that don't go for an ultrasound at all. If you have a patient with type 2, we're talking about type 2 diabetes and NFLD. Any patient of type 2 diabetes, take it for granted that he is having steatosis. And we go for the next step.
Thank you, sir.
And that would be going for a FIB score.
Thank you, sir. May I take this opportunity to invite our second speaker for today, Dr. Punit Saxena. And he is going to speak on sexual dysfunction in diabetes.
So I will not speak on what you are thinking.
Okay.
So
we'll discuss in the evening.
So good afternoon, everybody, and thanks, Dr. Vijay Patni. And it's for the first time I'm here. I missed the last few opportunities, could not make it because of the reasons back home. So I can see Dr. Vasant Kumar, Dr. Samar Banerjee, and so many other senior people, Tapas and other people in the audience. My friend Suraj Sen Gupta. We are from the same institute, based on which you will develop the novel therapies, basically. And these are the two common, we all know it's a very common problem, diabetic neuropathy, and nerve damage is going to happen over the period of time in all diabetics, whether it's type 1 and type 2. And these two are the mechanisms, hyperglycemia-induced damage, and two is the vasa nervosum, basically the microvascular problem. The nerve loses their micro blood vessels, and the axons, they dry up and they die finally. So neuronal ischemia. These are the two mechanisms and are the potential targets. So these all pathogenesis leads to different kind of presentations. Based on that, you have the classification of neuropathy, and this is the ADA classification, which is most commonly used by us. But we have slightly different classifications. If you see the neurological associations, they give a slightly different classification, but we are following these. So diffuse neuropathy, the DSPN, which is the most common neuropathy, that is diffuse symmetric polyneuropathy, which is the classical neuropathy which we teach to our students and which the patient also complain of. It can be predominantly small fiber, large fiber, or a mixed pattern. And then the second variant is the autonomic, which is a diffuse neuropathy, which is most often missed. And it can present sometimes even before the peripheral neuropathy, and you have cardiovascular, gastrointestinal, urogenital, pseudomotor, hypoglycemic, unawareness, and so many other functions. Then you have mononeuropathy, then you have mononeuritis multiplex, radiculopathy. And these are the compartments, the B and the C, which you often confuse with the non-diabetic neuropathy. The first one may be classical, but the... So, but the most important thing is to differentiate between the pain, basically, because whether it's a simple nociceptive response or whether it's a neuropathic pain. And there are many descriptors for the neuropathic pain, but these are the common presentations, right? So polyneuropathy is stalk and glowing, you can say glow and stalking. Mononeuropathies, then you have plexopathy, then you have autonomic neuropathy. And these are the basically prevalence, basically. The DSPN is responsible for almost 75% of all diabetic neuropathies, and 20% of type 1 diabetics will be affected by the neuropathy, whereas in the newly diagnosed type 2, 10 to 15% will show neuropathy. So that gives you an idea that you should probably screen the pre-diabetic patients also for neuropathy, because if they can present at the onset with 10 to 15%, so if whether you can see it, and it's a complication which is developing even before the diabetes is showing up. And 50% of those with 10 years or more type 2 diabetes will have, and this is the Indian prevalence, various studies, various data is coming in, but 18 to 51%, and some of them show even more than that. And if you see about the painful component, then almost 90% of these diffuse neuropathies will be painful. And these are the common descriptors, which I was telling you, the burning, the tingling, the shooting, the electric shock-like, and the numbness. This helps you in diagnosis, basically. You may not be having the best of the diagnostic modalities, but if you catch upon on these descriptors given by the patient, you can diagnose it. Allodynia, very frequently complained, but rubbed off as a functional symptom. Please pay attention to allodynia also. Risk factors, obviously blood glucose, then triglyceride, obesity, tall stature, smoking, hypertension, alcohol, nutritional deficiencies, drugs, comorbidities like malignancies, they all compound the problem. And if you see the pathophysiology, how the hyperglycemia, the insulin resistance, the dyslipidemia, what they are doing, they are promoting systemic inflammation and producing oxidative and nitrosative stress. And finally, it plays on the endoplasmic reticulum and the mitochondria of the Schwann cell. And you will have expression of all the chemokines, cytokines, the inflammatory markers. There is a cascade leading to neuronal damage. And this again is almost the similar representation, but the two components, the microvascular changes and the metabolic changes, these will be the potential targets in future for development of therapies. And there is some predilection for pain in the diabetic neuropathy also, like the genotype, the glycemic burden, the female gender, and certain kind of inflammatory markers. This again, I'll skip this. And what we do need to do about the diagnosis. So there are patient-related barriers, they will not complain, but we are concerned with the clinician-encountered barriers in assessing and treating the diabetic neuropathy. So catching it on a subclinical stage is very, very important. although we know that there is no disease modifying therapy, so don't ignore the problem or just to pass on the buck to the patient that, okay, you have to tolerate it, or I'm giving you some placebo or some painkiller or that kind of treatment. Then current symptomatic treatment is often inadequate. We all know that. Non-neuropathic etiologies of pain should always be evaluated, and health inequalities should always be considered, and not only the race, the gender, but also the socioeconomic determinants of health should also be considered while assessing the patient. So these are the signs and symptoms of neuropathy which are often missed. I want to stress on this. So somebody who is diabetic is complaining of exercise intolerance. You are looking for the angiogram, you're looking for the lung. Just think of the autonomic neuropathy. That can be a reason for a disproportionate tachycardia and exercise intolerance. Weakness, fatigue, the gastrointestinal symptoms, the nausea, the early satiety, the abdominal pain, which often is missed. The erectile dysfunction, the vaginal dryness, the involvement of the peripheral nerve, the positive and the negative symptoms and signs of the peripheral nerve, the skin appendages, the blurring of vision. Simple blurring of vision can give you, if you think, then it can lead you to think on the lines of development of neuropathy, and it corresponds to the science which comes in pertaining to that system. So diagnosis in clinical setting, take a targeted history, assess for the DPN symptoms, whether the small fibers are affected, the large fibers are affected, because the response to the treatment is different if the small fiber is affected or the large fiber is affected. Test for clinical signs of the painful neuropathy, and you can label them as either diabetic neuropathy, and if you're not able to label them, then please seek a consultation from a neurologist. Don't hesitate for that. There can be other causes, and obviously treat the underlying conditions if they are any other than diabetes. After that, you proceed to the investigations. So we have VPTV, all of us must be doing this at our centers, the vibration, but don't ignore it. I think every patient of diabetes should be subjected periodically to this test. Then you have the electrodiagnostic studies, the NCS, which not only confirm the diagnosis, but it can exclude other neuropathy mimics, subclinical involvement, the primary mechanism of damage which has come in axonal versus demyelination, that is also important, and the disease severity at last. So these can be the patterns which can you detect by NCS, the axonal loss, the diffuse demyelination, and the focal demyelination. And these are the biomarkers which are being developed, which correlate very well with the development of neuropathy and its severity. So there can be the MCP, that is some protein, metallochemical protein, and then there are growth factors, then there are adiponectin related factors, there are enzymatic biomarkers, then serotonin, another factor, the microRNA. The microRNA has been targeted also. So as per the guideline, FDA guidelines, assess all patients when they present to us, and annually thereafter for type 2 diabetes, and for type 1 it can be up to 5 years because they are young and they develop the neuropathy later on. And the tools, the VPT, the monofilament test, which is a bedside test, and the tuning fork, they can serve the purpose in the initial part when you have to screen the patient. So physical examination, the neuropathy disability score, there are various scales. The Lance score, the NPS score, the Dollar score, there are so many. You can use these score systems also. You can do nerve conduction. You can have the handheld devices these days which are available, which can assess the sural nerve or any other nerve. Then obviously monofilament testing. Then you can do a thermal perception test. There are gadgets for that. The pseudo scan, basically the sweating. 4 millivolt of current being passed, and you can see the channels, the chloride channels, which are responsible for production of the sweat. And same thing you can do by a neuropad test. Then you can do a punch skin biopsy to see the density of the nerves in the epidermis and the subepidermal region. So once you have screened and diagnosed, there comes the treatment. We have to play with whatever we have and have to manage those patients. It can be conservative physical therapies like reduction of weight, exercise, physical conditioning, massage therapy, placebo therapy works, health management, obviously optimization of glucose stands at the center and along with the management of comorbidities, then acupuncture, then TENS, then first line agents, and the most recommended agents. With class A recommendation is pregabalin, and with class B recommendation are others like duloxetine, gabapentin, and then you have SNRIs, then TCAs, then 8% capsaicin patch, and it has been approved by FDA, and then 5% lidocaine patch. It's high dose lidocaine. Normally we use 2%. It's 5% lidocaine. Then third and fourth line agents like analgesic like tramadol, tapentadol, and other opioids, they can be used. And finally, the interventions which are not frequently done. So dorsal column spinal cord stimulation, which can be 10 kilohertz or it can be tonic, and other neuromodulation like burst SCS, then dorsal root ganglia interference stimulation, peripheral nerve stimulation, and finally the intrathecal drug delivery system where you can deliver via pump or with an intermediary injection the morphine, the fentanyl, or other things which can numb the nerves which are giving you the pain. So for foot, again, it's almost a repetition. Same class of drugs are being recommended, and just moving on that. So what is shown over is the algorithm for the management of the patient. Pregabalin is the number one agent, but sometimes you don't get the response. You have to switch, either because of the lack of response or the side effects. You can combine the drugs, and we have combinations available like the pregabalin, duloxetine, or maybe these days amitriptyline and nortriptyline are very commonly combined and being used, and they are giving us good results also. So besides that, glucose management, as I've already told, optimization of the blood and the lipids, and then pain management. So that I think, and then there are adjunctive therapies like the lifestyle modification, then you have psychological options, counseling, then nutraceuticals, alpha lipoic acid and benfotiamine. Every other pharmaceutical company will come with these kind of combinations, and I advise you to use them for diabetic neuropathy. And I don't know how much they are helpful they are, but they are being studied. But proven deficiencies of vitamin B, D, or any other micronutrient needs to be corrected. Then interventional therapy, we have already discussed, especially for the painful. One more thing is the use of botulism. Refractory cramps sometimes can respond, all the level of evidence is 2B or 1B only. Then acupuncture, again the level of evidence is low, but then it can give you temporary relief. Then sympathetic ganglion block, neurolysis, then surgical decompression of peripheral nerves if you are suspecting entrapment neuropathies. There is a long list of new drugs which are coming up. They are in phase 2 and phase 3, and they have been represented here not even by their names, but they are different targets basically. The tyrosine kinase inhibitor, the angiotensin 2 type receptor, the cannabinoid receptor inhibitors, the gene therapies targeting the microRNA expression. So there is a long list, and I hope that they will see the light of day someday to help these patients. So there are unmet needs in the treatment of painful diabetic peripheral neuropathy, but early detection and clever play of medications and adjunctive therapies can alleviate the pain and the symptoms. So the take-home message is regular screening and early detection of diabetic neuropathy can prevent severe complications and improve quality of life. Maintaining optimal blood glucose is primary and the most effective way to prevent and manage diabetic neuropathy. And be aware of various symptoms. You can catch the patient early, and it can lead to prompt treatment. And finally, educating patients about the diabetic neuropathy self-care practices, foot care practices, and importance of adherence to the treatment plans is vital for successful management. Thank you very much.
Thank you, Dr. Punit. You have saved 2 minutes, so we can use that time for questions. Finish before time. Any question for Dr. Punit? Yeah.
So I could have overshot. I wanted to avoid that 2 minutes.
Excellent and extraordinary talk. Professor Saxena. Now, I would like to know that you have described in detail the peripheral neuropathy part. So, is there any relation of autonomic dysfunction and peripheral neuropathy?
Pardon, relation of?
I mean, is there small fiber neuropathies associated more with autonomic dysfunction or
With?
large fiber? Autonomic.
Yeah. So no, there is no direct correlation with that, but yes, autonomic neuropathy, small fiber will be affected first, majority of the times. So, and same thing happens with the autonomic dysfunction also. So it can go with that. Although the vibration is taken by the large fiber and you test for vibration first, right? But the symptoms, if you see, the hyperalgesia, the positive and the negative symptoms may come even before the loss of vibration perception. So that way, I think autonomic neuropathy goes more in.
And vitamin B12 is overused or maybe sometimes abused. So does vitamin B12 excess can cause deterioration?
Yes, it can cause deterioration. There can be paradoxical deterioration of neuropathy even if you correct the hyperglycemia very quickly. 1. 2, if you overtreat the pyridoxine toxicity and the other vitamin B toxicities can sometimes aggravate the neuropathy. They can itself cause neuropathy. So be cautious. So what I said is that correct the deficiencies only, that is the recommendation.
Are there any drugs to manage the negative symptoms?
You are absolutely right. You can use the same even if there is no pain, but you can still treat the nerve because what these pregabalin they are doing, they are basically affecting the channels basically, the ion-gated channels, right? So it will help in negative symptoms also, and then you can use, sometimes in negative symptoms you can use more of SNRIs along with the maybe venlafaxine or maybe duloxetine, that kind of drug can help better in the negative symptoms.
Last
Quick question.
Myself, Dr. Sharma from Calcutta. Thank you, Dr. Saxena, for his excellent deliberation. Just as you have been mentioned specifically in the last few slides and these things regarding the painful neuropathy, the management of painful neuropathy.
No, let me go back to that, okay.
So that these things is because is the domain of the neurology, diabetology or the pain management specialist nowadays?
No, you have to combine those. I think I just forgot because there are recommendations from the Pain Society also for treating the diabetic neuropathy. So you have a AAN recommendation, then you have AD recommendation, then you have European recommendation. There are all kind of recommendations. Even Indian Association of Neurology also recommends, right? So same way, the Pain Societies also they have their recommendations. So I think that would go. I have a few set of slides also with me. I can show you that also, but that will go beyond time. So maybe I'll share it with you personally.
Thank you, Dr. Puneet Saxena.
And sir, just last question, sir. Intrathecal injections, which sir has been mentioned, how much you people are practically using this at present in 2024?
So that is done by the pain clinic people, right? So that is the role of the pain clinic. And you must have seen that not for neuropathy, but you see these days TKR and THR being done very frequently. And there you see that temporarily for pain alleviation, they will put the pump basically, and they will pump in the opioid basically to alleviate the severe kind of pain. So if you take help of the pain clinic, probably, and I think these things will catch up with advancement and awareness and probably the increasing numbers and the affordability of the diabetic patients in coming times.
Thank you.
Thank you, Dr. Saxena. We move to the next talk now, and for that, I invite Dr. Surajit Sen Gupta.
So, free? Thank you very much.
So, Dr. Surajit Sen Gupta is a very senior physician and diabetologist from Delhi, and he is going to speak on cardiovascular complications in diabetes, novel approaches. Sexual malfunction. Sexual dysfunction in diabetes. Sorry.
So that's the more interesting topic which everyone was looking forward to. Hopefully, anyhow. So thank you, Dr. Patni, Dr. Amit, Dr. Shupratik, and team DRWA for inviting me to do this presentation. So I asked Dr. Patni, why me with this topic? He said, why not you? So believe me, during preparation of this talk, I also got a little wiser. So sexual dysfunction in diabetes, sex and sexual function as such is something which is discussed more behind doors, closeted, more so with sexual dysfunction, and unfortunately till now it was something which was not really discussed between the patient and doctors too oftenly. But thankfully now people are coming out, and there are solutions which are there. So briefly, in introduction, sexuality is an important aspect in the lives of most individuals and couples. And normal sexual function involves, however, the interaction and coordination of multiple components, including psychological, physiological, social, religious, and emotional factors. And chronic medical conditions such as diabetes may have an impact on many of these components, not only physiologically, but also psychologically. Diabetes, we know, is an increasingly prevalent problem that has been associated very strongly with sexual problems in both men and women. It has numerous end-organ effects and also exerts a substantial psychological toll which may predispose diabetic patients to sexual problems. And erectile dysfunction is common in men with diabetes. These men tend to present with more severe and refractory ED compared to the non-diabetic peers. While ED is the best established diabetes-related sexual dysfunction, ejaculatory and sexual desire issues may also occur in men with diabetes. Women with diabetes, and that's been at the back burner most of the times, and during the course of the presentation I'll allude to those also, are also at the risk of sexual dysfunction, and sexual health inquiry remains a very important aspect of diabetes care. And importantly, lifestyle change and close management of diabetes have been associated with improvements in the status of sexual function. These are the four main headings which I would be covering in males. Erectile dysfunction, diabetes happens to be the most common cause of ED, and up to 28% of men who complain of ED have diabetes as the primary causative factor. The ED is progressive in these patients, with more than 50% of diabetic men after the years of 10 years of diabetes tend to have this. However, it can also be the first presenting symptom in new onset diabetes. The most appropriate treatment of diabetes often produces a return or significant improvement in erectile function. It is often associated with microangiopathy, and the presence of retinopathy thus is usually a good predictor of ED. Age, duration of diabetes, and the presence of other diabetic complications correlates more with its future development. If you see the temporal and the age profile, between the ages of 40 to 70 years, the prevalence is almost 50% for the general population. And for younger men, it is about 7.8% for people less than 40. For men older than 40, it increases to almost 63% for type 1 diabetics and more than 70% for type 2. The use of alcohol and the older generation antihypertensives appear to increase the risk for ED in this particular population, whereas the newer generation antihypertensives are neutral to beneficial. On this small illustration, which shows on the left-hand side the flaccid penis, on the right, after engorgement, the erect penis, in which the interconnected lacunar spaces have been engorged. Now this is the pathophysiology of erectile dysfunction. On the left panel, you can see structural changes on the background of hypertension, dyslipidemia, and diabetes, having atherosclerosis leading to arterial stenosis. Where the functional changes, there is impaired endothelium-dependent relaxations, again causing impaired vasodilation, both leading to arterial insufficiency and reduced penile flow. Also, atherosclerosis and structural changes lead to, smooth muscle atrophy and fibrosis, whereas functional changes lead to impaired relaxation, causing veno-occlusive dysfunction, leading to excessive penile outflow. So, the erection doesn't actually stay sustained. The pathophysiology is multifactorial, consisting of both vascular, hormonal, and neurologic insults. And the diabetic neuropathy may impair autonomic and somatic nerve processes essential for erections. It is also associated with impaired relaxation of cavernosal smooth muscle due to endothelial-derived nitric oxide-induced glycosylation products. And a variety of serum markers like E-selectin, interleukin-10, reactive oxygen species have been linked to the diabetes-related ED. Now, in treatment, oral therapy is the best first line. The only effective ones are the PDE5 phosphodiesterase 5 inhibitors, sildenafil, tadalafil, vardenafil, and avanafil. The last two are not available in our country. Provided that there are no specific contraindications like unstable angina, diagnosed CAD, nitrate therapy, pelvic surgery, or spinal cord injury. All the PDE5 inhibitors are dependent on function of the nitrous oxide CGMP pathway. The sexual stimulation provokes the release of nitrous oxide from the cavernous nerves and endothelial cells, leads to activation of guanylate cyclase, which catalyzes the transformation of GTP to cyclic GMP, which in turn triggers the decreased intracellular calcium with subsequent relaxation of the actin-myosin cross bridges. And cGMP is deactivated by conversion to 5/GMP, a process mediated by PDE5. This is the basic process which is inhibited by the PDE5 inhibitors. And in a large double-blind study of around 270 odd diabetic men, erections were improved by almost close to 60% of patients who received sildenafil compared to 10% of men who received placebo. And intercourse was successful in almost 50% of the people compared to about 10% of the men who were given placebo. Now, if oral treatment is not effective, what are the other options? There are mechanical options, the vacuum erection device, intraurethral prostins, alprostadil, which can be given, intracavernosal injections of a vasoactive substance like prostaglandin PGE1, papaverine, phentolamine, which can be given as a bimix or a trimix, or a penile implantation. And individual preferences, patient preferences and costs, they determine the next step. Now this is an intracavernosal injection of a bimix or a trimix which can be given. Intraurethral alprostadil, prostaglandin, which can be done in this manner. Vacuum devices, penile processes, which can be done. The next, diabetes and low libido. Low libido is the term used to describe lack of interest in sexual activity. Sexual desire or libido is produced by a combination of biological, personal and relationship factors. Causes are low testosterone levels and psychological causes. And controlling blood glucose levels may help to improve feelings of sexual desire. Men who have low libido due to androgen deficiency may need testosterone therapy. Next is androgen deficiency. Testosterone is the most important androgen in men and it is needed for normal reproductive and sexual function. About 30% of men with type 2 diabetes have low testosterone levels, and men with type 2 diabetes are more likely to have low testosterone levels if they are also obese. Symptoms are of low energy, mood swings, irritability, poor concentration, reduced muscle strength and low sex drive. The men with diabetes should be screened for the presence of low testosterone by checking serum total testosterone, and sex hormone binding globulin and albumin may also be tested in tandem to permit assessment of free and bioavailable testosterone. And testing for hypogonadism should be performed in the morning hours between 8 and 11 a.m. where serum testosterone levels are the highest, and the appropriate assay and the biochemical cutoff values for low testosterone, though controversial, are taken as the figures as mentioned out here. And when assessing a patient with a single report of low testosterone, care must be taken to do a reconfirmation of testosterone as well as the other pituitary hormones like FSH, LH and prolactin to rule out central causes of hypogonadism. And if androgen deficiency, the basic prevention is keeping a healthy weight and regular exercise that is within the domain of the patient to control blood glucose levels and may help to keep the testosterone levels normal. Only those patients with biochemically low testosterone and symptoms potentially referable to hypogonadism, that is decreased libido, ED, fatigue, decreased bone mineral density, depressed mood, etc., in which alternative etiologies have been ruled out, should be considered for treatment. Also control diabetes better, control weight, and obviously give testosterone where applicable. Balanitis. Men with balanitis may not be able to pull back their foreskin or have itchiness, rash, redness and swelling or discharge from the penis. After urinating, some urine can often get trapped under the foreskin. And in men with diabetes, and this again happens in people on SGLT2 inhibitors, the moist area and the glucose in the urine can lead to bacteria growing and then infection persists. Antibiotics and antifungal treatment may help clear up the infection, and washing the penis and the inside of the foreskin with soap and water helps in controlling the infection. Now, next is the female sexual dysfunction and disorder. This is the American Foundation for Urogenital Disease, which classifies the female sexual disorders in this manner: hypoactive sexual desire disorder, sexual aversion disorder, orgasmic disorders, sexual pain disorders which incorporate dyspareunia and vaginismus, and other sexual pain disorders. Now, hypoactive sexual desire disorder, it is persistent or recurrent deficiency or absence of sexual fantasies or thoughts or desire for a receptivity to sexual activity. It obviously causes huge personal distress, and the differential diagnosis remains surgical or medical: menopause and other endocrine disorders. Sexual aversion disorder, it is persistent or recurrent phobic aversion to and avoidance of sexual contact with a sexual partner, again a cause for personal distress, results usually from, unfortunately, childhood trauma, physical and sexual abuse. Sexual arousal disorder, persistent or recurrent inability to attain or maintain sufficient sexual excitement, again a reason for personal distress. Differential diagnosis remains medical causes: prior pelvic trauma, prior pelvic surgery and medications, and may be expressed as a lack of subjective excitement or lack of genital lubrication or swelling. Orgasmic disorders, which is persistent or recurrent difficulty / delay in or absence of attaining orgasm following sexual stimulation, again a cause for personal distress. Primary, it can be primary in which the person has never attained orgasm because of emotional trauma, sexual abuse early in life. Secondary to surgery, hormonal deficiencies and trauma. Next is sexual pain disorders. First is dyspareunia, which is recurrent or persistent genital pain with sexual intercourse. One must consider vulvar vestibulitis syndrome, in which there is either, severe pain on vestibular touch on attempted vaginal entry, tenderness to pressure on vulvar vestibule, or vulvar erythema because of infections or other causes, vaginal atrophy and vaginal infection. Next is vaginismus under the heading of sexual pain disorders, in which there is recurrent or persistent involuntary spasm of the musculature of the outer third of the vagina that interferes with the vaginal penetration, and it's a conditioned response to painful penetration often. These are the other sexual pain disorders: HSV virus infection, vestibulitis I have referred to, history of prior genital mutilation, which is unfortunately a bad social stigma and found in very many societies, trauma, endometriosis and interstitial cystitis. Now these can be clubbed in various formats under the four main headings of sexual disorders in diabetic females. First is autonomic neuropathy, which this is a common complication of diabetes, and it can lead to poor bladder control and poor vaginal lubrication. This also results in discomfort and inconvenience, which may affect a woman's libido. Poor bladder control occurs when the nerves to the bladder are damaged, and this may lead to an inability to empty the bladder completely during the time of intercourse. And women are advised to urinate before intercourse and within 30 minutes after. Poor vaginal lubrication can occur if neuropathy affects the nerve fibers that stimulate the genitalia so that arousal may not occur, thus making intercourse painful, which is dyspareunia, because the lubrication fluids are not produced, and this situation can be somewhat helped by the use of a lubrication jelly. Low libido, it can be caused by psychological factors such as depression, tiredness, or hormonal problems, or linked to certain medicines. The medicines that can affect a low sex drive or cause a low sex drive are tranquilizers, OCPs, antidepressants, and older generation antihypertensives, some of which are pretty much commonly used by people with diabetes. It is advisable to discuss this with one's doctor to consider changing medications commensurate with the clinical situation. Poor sleep may also alter a woman's libido, and a study has shown that low libido during menopause may be linked to disturbed sleep. So these factors need to be treated. Pain during sex or dyspareunia can be superficial or deep pain. Superficial is often produced by infections such as thrush, common in women with diabetes, or by vaginismus, a condition that causes low vaginal muscles to go into spasm. And deeper pain can be caused by the lack of lubrication or stimulation, or by conditions such as PID and endometriosis. Hypoglycemia is somewhat which is seen, though not very common, during sexual intercourse. It is well recognized that intercourse uses up large amounts of money, up to 500 calories. The whole joke for men being about running the same, a 4-minute mile. Obviously, the same in a different format applies to women also. But diabetic women should also be aware of the potential hypoglycemic episodes which may occur during and after sex. And it is advisable in such people who are vulnerable to check the blood sugar levels before and after sex, and awareness always helps. So in management, basically, the patient should be talking to the doctor about the problem, do away with hesitation. And multidisciplinary support and management is required. Astute sugar and blood pressure control is the keystone. Stop antidepressants as indicated, relevant drug therapy as required. Try and lose weight, which increases the patient's self-esteem. A gynecologist may be incorporated in the treatment strategy to take care of the conditions like UTIs, urinary incontinence, estrogen therapy, and vaginal lubricants, etc. Psychiatrist and psychological support is often very necessary, and so is family support. From the patient's perspective, make an effort to control blood pressure with stress reduction techniques. Control blood glucose well. If overweight, make an effort to lose weight. Commit to a diabetes care regime properly. If vaginal dryness is a problem, make liberal use of lubricants and consult the gynecologist. Relationship problems, especially extramarital ones, etc., can interfere with the desire to have sex, so have those things sorted out at a social level, and reduce the likelihood of urinary incontinence, which may be complicating this. So when the patient is with a doctor, the doctor should also be forthcoming. He should not think that the patient has to bring it up. He should be forthcoming and forthright in taking it up as a complaint and ask pointed questions. And likewise, this is the last slide. Yeah. The patient should also be forthcoming itself, so that there is a solution which can be found to the level or the degree of the problem that he might be having. So thank you very much for a patient hearing. And it's my privilege to invite all of you for the RSSDI National Conference that we would be hosting in Delhi later this year from the 14th to 17th November at Yashobhumi, which happens to be the largest conference center in Asia right now. It's truly a sight to behold, and we would be delighted to host each and every one of you. Looking forward to meeting all of you out there. Thank you.
Thanks, Dr. Surjadeep, for nicely covering that whole topic. Is a large topic within the limited period of time. So I would like to add only few points.
Yes, sir.
While evaluating for sexual dysfunction, whether it is in male or female, we should also keep in mind the other endocrine disorders like hypothyroidism, hyperprolactinemia.
Yeah, that's what I said. Those things need to be considered. Absolutely.
Endocrine disorders like
Absolutely.
Cushing and
I mentioned that.
acromegaly. If the signs and symptoms suggestive of that, we should evaluate. And another thing is regarding the female sexual dysfunction, that could be autonomic manifestation, autonomic neuropathic manifestation. Vulvodynia is very rare, but is a recognized complication of autonomic dysfunction in female. I have seen few patients, the vulvodynia, that could impair the female sexual life as well. So now the house is open for question and answer.
The good thing is that people are now at least coming out of the closet and discussing it with more openly, and some solutions can definitely be found with mutual consent and treatment strategies.
Any question from the floor?
Role of testosterone therapy, patients, male patients having hypogonadism,
Yeah, so like I mentioned, you first confirm whether it is actually true, so you do a repeat testosterone level and also do the central hormones, I mentioned FSH, to rule out central hypogonadism, and then treat accordingly.
Dr. Surjadeep, here, Dr. Rakesh, this side.
Yes, sir.
Okay. So just wanted to add something. We see a lot of young people nowadays coming with the complaint of young people, young diabetics, recently diagnosed diabetic, and they come up with the complaint of ED. Many times it's psychological, because they have just heard somewhere that diabetes affects your sexual function. And in those patients, I think the reassurance work very well.
Yes.
So if you just ask them about the early morning erection, they are getting it.
ED, a large component is psychogenic. So, that has to be taken into consideration, and the patient, rather than being scoffed at or just talking loosely, he has to be taken into confidence and dealt with in a very rational manner. And most people do brilliantly well. They would not need therapies. And then once counseling is done properly, and very importantly, at times this becomes a social stigma within the family without realizing it. So if the family is on board, that becomes an excellent platform for the patient to improve very well.
I would like to add few more points. While evaluating and taking history, we should not neglect the history of smoking and alcoholism. And overall, we should take the history suggestive of obstructive sleep apnea syndrome.
Yes, usually
that
people
could be a very important factor
I mean,
for erectile
absolutely.
dysfunction.
I mean, very many of such people, when they come to us in terms of, in presentation and serve your practice and all of us, they are usually, if you see, more of the withdrawn type. So that could be one of the indicators that you start talking to them in a more compassionate manner and try to elicit that history where they are suffering from these. Because often such people lapse into depression, and that becomes a kind of a vicious cycle from which it's very difficult to come out, and nobody is wanting to talk about it. So a good history obviously forms the absolutely excellent clinical base for things.
Last query from Dr. Puneet again.
I just want to congratulate you. Have taken a very nice topic because it's often neglected and rightly highlighted. Yeah. So what Dr. Tapas was asking about the testosterone supplement, what according to you would be the best kind of testosterone supplement? And I personally feel that we are not evaluating for basically free testosterone that often, and very often the sildenafil or tadalafil kind of medicines are being prescribed for EDs without looking into the actual cause.
True.
So what kind of testosterone supplementation according to you would be the best, because there are so many available? So what are the recommendations?
One can try with the oral supplements which are available after having confirmed, but in case there is some need and you follow it up, then injectables can also be given.
I think we can take no more question. Now we will move on to the next topic.
All the best for National RSSDI. See you there. Thank you.
Now we are moving on to the next topic. The topic is cardiovascular complications in diabetes, novel approaches to risk assessment and management. That would be delivered by Dr. Taposh Bandopadhyay. Welcome, Dr. Bandopadhyay.
Persons and the organizers, particularly Dr. Vijay Patni, Dr. Amit, Dr. Mary, Dr. Supratik. It's very nice to see so many old friends here and meet so many faces, known faces. So thank you, the organizer, for this talk. So my talk is actually on the novel approaches in risk assessment and management in cardiovascular complication in diabetes. So I will not discuss the things that are already conventional, like statins, ezetimibe. Rather, I will discuss a few novel areas and highlight on those points. So as you all know, type 2 diabetes is recognized to be linked to higher rates of cardiovascular mortality, and patients with diabetes have a reduction in life expectancy to the tune of 4 to 8 years compared with the individuals without diabetes. Cardiovascular complication in diabetes is the leading cause of death. There are many major cardiovascular complications you all know: CAD, stroke, peripheral arterial disease, heart failure, arrhythmias. And patients have a greater risk of coronary artery disease and stroke in someone with diabetes. The number of deaths in people with diabetes attributed to cardiovascular disease. So when we approach a patient suffering from cardiovascular risk reduction, we should focus on the risks like glycemic management, like lipid management, management of strict control of blood pressure, and screening for cardiovascular disease, and use of antiplatelet drugs. So I will come to that. We all know that advanced glycemic markers are HbA1c, fructosamine, inflammatory markers like hsCRP, interleukin 6. Now I will focus on the carotid intima media thickness. This is very important. It's a surrogate marker for new acute myocardial infarction and stroke in individuals above the age of 65 years, when maximal intima media thickness is above 1.1 millimeter, both in common and internal carotid arteries. Another important marker independent of other risk factors is ankle brachial index. We all know how to measure the upper limb and the lower limb, ankle and the brachial blood pressure. A low brachial index, ABI, score of less than 0.9 is associated with elevated cardiovascular risk. Lipoprotein is another area which has got importance in recent times. The screening of patients for LPA could help identify those at higher risk for heart disease, especially in absence of other major risk factors. no major risk factors are there, you can go for a lipoprotein A screening. And a lifetime, the person must having family history of premature coronary artery disease must have the screening of lipoprotein A if other risk factors are not there, like dyslipidemia, hypertension, etc. The suggestion has been made for younger patients, coronary artery disease can be explained by lipoprotein A without or with other risk factors. And more than 50 has increased risk of cardiovascular disease. Another important novel biomarker is coronary artery calcium score by multimodality CT scan. The CSC score is independent marker again for risk of cardiac events, mortality and all-cause mortality. In addition, it provides additional prognostic information to other cardiovascular risk markers. Atherosclerotic plaque that proceeds through progressive stages where instability and rupture can be followed by calcification provide the stability to an unstable. This is the coronary calcium test scores. 0 is no calcium detected and 300 plus is the moderate to severe increased risk of heart disease. That is the highest score. More than 400, high calcium score is consistent with significant risk of having a cardiovascular event within the next 5 years. And it is well established that indications for the use of CSC score include stratification of global cardiovascular risk for asymptomatic patients. Symptomatic patients, the value is limited. But asymptomatic patients, it has got importance. Intermediate risk, based on the Framingham score, risk score class 1. Low risk, based on a family history of early coronary artery disease, is the class 2 indication, 2A. And low risk patient with diabetes, again class 2A indication for having a coronary artery calcium score. In patients with diabetes, the CSC score helps identify individuals most at risk who could benefit from screening for silent ischemia and also from more aggressive clinical treatment. These are the risk calculator that is available online by different societies, ASCVD risk factor, prevent, score 2. I am not going to the detail. Then again, this is the novel approach to risk management. So lifestyle, as you all know, is already it is established that one individual should have more than 150 minutes of moderate to vigorous intensity aerobic exercise per week for a period of at least 3 weeks without any intervening consecutive 2 days without activity for most adults. And other criteria is also there. Shorter duration of vigorous exercise or interval training may also be considered. Increased physical activity exercise have been shown to improve glycemic control, lipids, blood pressure, insulin sensitivity, inflammatory markers. Then again, lifestyle modification in the form of diet, a low carbohydrate, high fiber, Mediterranean diet, high protein, veg diet, and nut-enriched diets have demonstrated benefits for good glycemic control and also significant weight loss in type 2 diabetes is associated if done along with moderate intensity aerobic exercise. So this is the Mediterranean diet pyramid where processed food and packaged foods should be rare, rather vegetables, fruits, whole grains, this will be the main bulk of the food. The plate should look like this, low carbohydrate diet and not going to the keto diet. So obesity is another area which should be given due importance because obesity is increased with cardiovascular risk of 2-fold or more, you all know, and this metabolic syndrome has increased the cardiovascular risk by many-fold, and these are the drugs that are approved by the FDA, particularly the oral GLP receptor agonist. GLP receptor agonist in the injectable form like liraglutide or injectable semaglutide. Surgical management, bariatric surgery, I am not going to discuss. Glycemic targets, hyperglycemia increase the risk of CVD in type 2 diabetes, and 1 unit of increase in HbA1c among individuals with diabetes increase the risk of macrovascular disease. There is observational studies to show the lowest mortality of at A1c of 6 to 6.9 with a dose-dependent increase in mortality with each unit of increase in A1c. These are the different trials of CBOT trials, and you all know that liraglutide, the leader trial, the sustain 6, the semaglutide, the injectable semaglutide, then dulaglutide, rewind, and lately the Pioneer 6, Pioneer 7. So this is the oral semaglutide trial.